Hey guys, Yulia back here with Nerdy NP. I have a little bit of a change of scenery. My car doesn't have air conditioning, so today it will be a fireside chat. Hopefully you guys don't mind. Today we'll be discussing two other heart failure drugs. One is Ivabradine and one is digoxin. So in order to understand how these drugs work, we first have to talk about something called the sinoatrial node, which, if you guys know, is the pacemaker of the heart. So it's located in the right atrium, and it generates action potentials that then trigger contraction of the heart muscles, and this action potential or electrical impulse then travels from the SA node. It moves to other cardiac muscle cells, depolarizes the cells in the atria, and then moves down the AV node, and then slows down the conduction a little bit to allow time for the atria to fully contract before then the impulse then gets moved to the Purkinje fibers, and then that will cause the ventricles to contract. So the thing to know about the SA node is that it is automatic. So even if you took the SA node out of your body, it would still be able to generate these action potentials. And so how it works is, I have a little bit of a diagram here. So an action potential is an electrical impulse that then generates a contraction of the cardiac muscle cell. So in the SA node, or the pacemaker of the heart, we have something called the funny channels. The funny channels are in the membrane of the SA node, and they allow sodium to flow downwards. So this influx of sodium then causes this membrane here, this cardiac cell membrane, to become more positive. So when the sodium channels open, your membrane is down here, let's say at -60. And then as the sodium is flowing in, then this membrane becomes more positive at, let's say, about -50 or so. And then this triggers your T calcium channels to open, and calcium flows into SA node. And then this causes it to be even slightly then more positive, which then triggers the final channel, the L calcium channel, to open, and that finally causes your action potential or your cell membrane to reach its threshold, and this generates your action potential or your cardiac electrical impulse, which then later results in a cardiac muscle contraction and what we call a heartbeat. And this happens during every single cardiac cycle. Every single heartbeat, it happens the exact same way. So what does Ivabradine do? Ivabradine blocks this funny channel here. And so what happens is then the sodium is not able to enter, which means that you do not get this positive change in the membrane. And so then that delays the opening of the T calcium channels and then the L calcium channels. So essentially this whole action potential is then delayed. And so because the time between the action potentials is longer, because it takes longer to depolarize this SA node cell and to allow it to reach threshold and cause an action potential, which will then cause a heartbeat, because of this longer time interval between action potentials, we find that our heartbeats are occurring less frequently. So essentially our heart rate is lower. And obviously if we have a lower heart rate, then we have decreased oxygen demands on the heart. And if we have decreased oxygen demands on the heart, that relieves our heart failure symptoms, angina, shortness of breath. So that's one thing. Another thing is Ivabradine, by decreasing the heart rate and increasing the interval of time between action potentials and between the next beat, we're actually allowing for the diastolic period to be longer. So this period of relaxation is longer, and that allows more time for filling. So what does that mean? Remember when we talked about preload and the heart filling up with blood for the next cycle? That preload or that diastolic period allows for a higher preload. So longer diastolic period, more time to relax, more time to fill up with blood, so a higher preload. And higher preload means higher stroke volume, and higher stroke volume means higher cardiac output. And higher cardiac output means better perfusion to our organs. So in summary, Ivabradine causes a longer diastolic period, more time to fill up with blood because of a lower heart rate, and in turn, a longer diastolic period and longer filling period improves coronary artery perfusion, because coronary arteries are perfused during this relaxation, this diastolic period. And so the longer this period, the more time we have for the coronary arteries to perfuse, better coronary artery perfusion, lower heart rate, so less oxygen demand, and higher preload because we have more time between heartbeats. So this is the mechanism in which Ivabradine helps to improve heart failure symptoms and angina. But things that we need to keep in mind is that we can't start Ivabradine on everybody. So Ivabradine can only be started in a couple scenarios. One, your EF has to be less than 35%. Your ejection fraction has to be less than 35%. Your heart rate has to be greater than 75 on maximally tolerated beta blocker therapy. So let's say you're already on 100 of toprol and your heart rate's still greater than 75 and you're still having heart failure symptoms and you're still having chest pain and your EF is less than 35%, then you can start Ivabradine if you have a normal heart rhythm. So let's say you cannot have atrial fibrillation or any other arrhythmia. And also you cannot have any heart blocks. You cannot have like first or second or third degree heart block. So to recap, Ivabradine can be started in patients with EF less than 35% who are on maximum beta blocker therapy and still having symptoms and the heart rate is greater than 75 and they're in normal sinus rhythm with no arrhythmias, no atrial fibrillation. And the things that we have to obviously look out for with patients on this drug is bradycardia. So our goal is to induce bradycardia, but we don't want them to have heart rate in the 20s and 30s because obviously we know heart rate is one of the components that influences cardiac output. So if our heart rate's too low, we're not going to get perfusion to our organs because our cardiac output's going to be too low. And patients going to feel really sick, short of breath, dizzy, might pass out. So that's one thing. And then also Ivabradine, because it blocks those funny sodium channels, those funny sodium channels also exist in the retina. And so a lot of times people get this kind of luminous phenomenon where everything just appears brighter. And the reason why this happens is because those funny channels are blocked in the retina as well. And so if a patient comes complaining of those symptoms, you'll know what to educate them on, and possible, discontinuation of the medication may be in order depending on, how troubling this symptom is. So that is Ivabradine for us today. And in the next video, we will focus on digoxin.